Hey everyone, hope I am audible and clear.
Yes, Shripriya.
Thank you for confirming. So welcome back everyone to the 15th session of our foundation course in palliative medicine. Today we are going to discuss about a very vast topic, palliative care emergencies, and we have a very eminent faculty, Dr. Barathi, joining us in the evening to walk us through the session. And we have Dr. Sridevi Warrior also joining us as a facilitator who is heading the Education and Skill Building Department of Palliative India. So for formal faculty introduction for the session facilitation, I invite Dr. Sridevi Warrior over. Ma'am, it is over to you.
Thank you so much. Today I'll be facilitating the session. As Shripriya mentioned, palliative care emergencies do really exist. Emergencies do exist in palliative care is one thing that I would like to convey at the outset. And today we'll be going through the common emergencies that might be the common among other settings also, but maybe the management strategies and outcome or goals of care will be a little different. So I'm not giving the details anyway. Dr. Barathi is with us today to talk more about palliative care emergencies. She has done her master's in palliative medicine from Cardiff University, also PhD from Lancaster University, UK, and she has done her PG diploma in geriatric medicine also. So she has experience working in tertiary care center as well as many international palliative care setting, and she was an honorary consultant with Cardiff University, and she's also there in the steering committee member of EAPC's European Association of Palliative Care. So they have a huge research network, and she's a part of the steering committee. And she's associated with organizing webinars and research topics. And she has many publications. And very interestingly, her field of interest is non-malignant, the palliative care in non-malignant disease. Of course, we all are facing that in the coming or in the ongoing days. Non-malignant and geriatric palliative care is a huge need in the country, I think, as well as in the international scenario. Thank you, Dr. Bharati, for being with us today. Which part of the world that you have joined us from?
Thank you. Thank you for the introduction, and thanks for the opportunity to teach with Palliative India. Yeah, this is my first time, I think, teaching here for the course, foundation course. So before we'll go into the topic, I would like to just to know, are there any oncologists in the group? You can like raise your hand in the, you can use the hand symbol in the Zoom. Okay, I don't see any hands. All right. Okay.
I'm sure there are a few in this group. I'm not sure whether
okay.
Yeah, there are a few oncologists.
Okay. All right. Okay. Yeah, fine. This is just to know that, so what kind of audience that I have, so that I can tailor the information that I'm going to provide. Okay. All right. So I'm going to share the screen. Are you able to see my screen?
No, ma'am.
Not yet.
Not yet. Okay.
Ma'am, can I share the PPT?
1 second. Be able to see now?
Yes, maybe in the full screen mode, but otherwise we are able to see your screen. It is
Okay.
not in the slideshow mode as of now.
Okay, wait. Okay. I think it's in the slideshow now.
Yes, yes.
Okay. Right. So today we are going to talk about emergencies in palliative care. So I don't know how many of you have had this question, wondering whether there will be any emergencies in palliative care. We all have, we are all treating dying patients, right? So if at all there is an emergency, should we treat or shouldn't we treat? I'm sure you would have had ethical session earlier, I think. So there's going to be always a dilemma to treat or not to treat. But emergencies definitely in palliative care do occur. And palliative care, as we all know, it is not a passive care, right? We actively treat patient. So we should be treating emergencies, but to what extent we can go is what we need to determine with the clinical presentation and in discussion with the team and along with the patient and their family. So I put some 6 topics for this today's presentation, which are commonly seen in palliative care setting. So we will be discussing all of this briefly. Before I proceed, I guess there is a case presentation at the end. So may I know what is the topic of the case presentation?
Ma'am, actually, we don't have a case presentation for the day because the participant who was supposed to bring in was not able to. So, in effect, the entire time is for you. Like you can discuss more if you want, and we have time till 6:30 to be precise.
All right. Okay, fine. I mean, I have some scenarios in my mind, but I haven't put it in the slide. Maybe I can. I think it's better to learn. Sorry.
Sorry to interrupt, but if you have case scenarios, we can definitely discuss that, and then you can share the revised deck with us. No worries.
All right. Okay. So I think that will give some idea. Then it's put the emergencies in the right perspective if you have the case discussion. And if there are any questions, I would like the audience to ask the question at the end of each topic. So, like for example, if you finish hypercalcemia, then we can have some time for question and answer in that particular topic, because today we'll be covering different topics. So it's not, you don't have to wait until the end. So we can take questions at the end of each topic. Okay, the first one that we're going to see is hypercalcemia. This is a very common emergency that can present in palliative care clinic. So hypercalcemia refers to raised levels of corrected calcium in the blood. So the normal range you can see in the seat in the bracket, it is between 2.1 to 1.2 to 2.62 millimoles per liter. Hypercalcemia is common in myeloma, breast, renal, lung, and thyroid cancers than in other cancers compared to other cancers. So this, when we say hypercalcemia, we always need to remember that we are referring to corrected calcium in the blood, not the absolute calcium. So you can see the formula given at the end of the slide. So this one we need to remember when we discuss hypercalcemia. So what are the common symptoms? So before we go into the common symptoms, I want to just describe a case scenario. Middle-aged lady was admitted in the oncology ward with tiredness, thirst and constipation. She had back pain earlier, but she said that it became severe for the past 3 days. So the oncology was highly suspicious of myeloma because she was not diagnosed with any malignancy in the past. She was referred from medicine department to oncology with high suspicion of myeloma with the symptoms that she had, and her blood counts are also were compromised. So with high suspicion, we did the blood investigations, and her corrected calcium level was 3.5 millimoles per liter. So we immediately started IV fluids and other treatment. So this lady did not have any other symptoms. She was only complaining of thirst constipation, and vague tiredness. She always feeling tiredness for the past 3-4 days. And the pain was severe. That was the reason why she came to the hospital. So in mild hypercalcemia, the diagnosis goes by suspicion. Even sometimes if they do not have a malignancy already diagnosed, sometimes hypercalcemia brings the patient to the hospital, like this lady. So remember the symptoms. I always tell my students to remember the symptoms from head to toe, so you can go chronologically and you don't miss any symptoms. So feeling of thirst, nausea, tiredness, polyuria, constipation, and pain can be exacerbated. In severe hypercalcemia, the symptoms can be more pronounced. Patient can have vomiting, they can have ileus, and patient sometimes can present with the drowsiness and also be delirious. In severe cases, patient can have seizures and can go into coma. So severe hypercalcemia, you don't miss to diagnose because they present with more acute symptoms than mild hypercalcemia. So how do we diagnose? As we just discussed, we need to check for the symptoms of hypercalcemia and do blood investigations to find the corrected blood calcium level, and also should do GFR to titrate the medications, especially in patients with compromised renal function. So the management depends on the level of corrected blood calcium levels. So if the calcium levels, corrected calcium levels are between 2.1 to 2.8, then IV fluids are just enough to treat the symptoms. So just keep rehydrating and monitor for worsening of symptoms. That will tell you whether to start with bisphosphonates or not. If the blood levels are above 2.8 millimoles, then we need to consider starting bisphosphonates. So there are two drugs of choice. One is zoledronic acid, another one is disodium permanganate. Zoledronic acid is the cheapest one, and in many palliative care settings, this is the drug of choice because of its affordability. But in case of renal failure, this drug needs to be titrated, where some physicians prefer to give disodium permanganate for renal failure patients. And please do a GFR before starting bisphosphonates. And in my cases, zoledronic acid single dose is enough. And also in renal failure, after the single dose, then you can check the calcium levels again and then decide whether to continue treating or stop the bisphosphonates. So moderate hypercalcemia is where levels exceed 2.62 millimole per liter. It can go up to 4 millimoles per liter. So IV fluids should be given 1 to 3 liters, and bisphosphonates. So again, remember the drug of choice depends on the affordability and the presence of renal impairment. And monitor for electrolytes and urea because it can impact these parameters. Severe cases, you can find the blood calcium level is above 4 millimoles per liter. So along with IV fluids, bisphosphonates need a longer duration for the calcium level to be corrected. So it needs to be titrated and then checked again for the correction, and electrolytes needs to be monitored, and also the GFR. In severe cases, one caution to be taken that patient can go in for arrhythmias and seizures. So if patients are presented with 4 millimoles of corrected blood calcium level, then you need to also consult a cardiology and a neurology for monitoring this symptoms. Then never forget to explain to the patient and the family what is going on. Don't keep them in dark. And as we always do in palliative care, explain as the treatment progresses, and tell them what is going to happen and what is the treatment plan, and also discuss with your team and your oncology colleagues, and monitor the blood parameters and follow. So, any questions? You can raise your hand, putting the symbol, or unmute yourself and ask if you have any questions. Looks like everyone is clear about the hypercalcemia treatment. So I'm proceeding to the next topic, hemorrhage. Okay, hemorrhage is the most frightening and awful symptom for anybody. It puts us in a situation like don't know what to do. Even the physicians, we get stuck. And so,
Dr. Bharati, just one, sorry to interrupt. There is one question in the chat regarding pain, and I think its question is like pain where? Maybe it's he's asking where will you find pain when hypercalcemia? And there is another question on dose of zoledronic acid.
okay, so pain could be an existing pain. So if it is myeloma, patient usually have back pain, so that pain can be exacerbated. Or depending on the site of malignancy, they can have pain. So that pain, which was already there, can get severe in hypercalcemia. Or patient
And
can.
there is a question on.
Yeah.
A question on dose of zoledronate also.
Okay, I'm not able to see the chat because I'm in full screen. Wait.
Because you are presenting, so it may not pop up for you.
Okay, so can you tell me what is the question? Dose of
Question
zoledronate.
is the dose of zoledronate, and there is one continuing question to the pain question, that is it bone pain?
It need not be bone pain all the time, but it could be sometimes vague. But sometimes patient, if they are very intelligent, they can pinpoint pain, back pain or pain in the thighs, they can pinpoint the pain. Dose of zoledronic acid is 2 to 4 milligram. So you need to give it as an infusion over 15 minutes, slow infusion. And for pamidronate, it is 50 to 100 milligrams.
Yeah, that's it about the questions in the chat, but I think we can go ahead.
Okay. Right. So hemorrhage could be more frightening and awful, and put us into the situation of don't know what to do. It's sometimes, we get stuck with the frightening blood that we see in the situation. So hemorrhage could be, it could be in any form. Patient can have, depending on the site of malignancy, it could be hemoptysis or hematemesis or a bleed from a catastrophic bleed from a malignant wound, or bleeding per rectum or vagina. So these are the common modes of presentation of hemorrhage. So we will see 3 kinds of presentation in hemorrhage. So hemoptysis. Hemoptysis is described as blood in the sputum by the patient. So patient usually say streaks of blood or blood mixed with sputum, or just blood, no sputum at all. So that gives you a clue of the severity of hemoptysis that the patient has. Sometimes it could be just mild, where they bring about 2 to 5 ml of blood, but anything which is beyond 15, 20 ml, then we need to, take measures to, keep the patient comfortable and treat the patient. Hemoptysis can be associated with cough, pain, and dyspnea. So the common causes for hemoptysis could be direct tumor invasion or erosion of the lung structure, or could be infection, pulmonary thromboembolism, and severe heart failure. So these conditions can cause hemoptysis. So how do we diagnose hemoptysis? I mean, you can see like from the symptom, you can diagnose hemoptysis, but these investigations give us a clue how to manage the patient. So always do a blood grouping and RH typing. So if patient has a massive bout of hemoptysis, you can treat the patient, and also the coagulation profile ready, prothrombin time, bleeding time, and INR. And as for lung X-ray, which can show you any infection or associated pleural effusion or tumor, growth of tumor, and MRI for a more clear picture of where exactly the tumor is invaded. And if it is involving the bronchopulmonary tree, then there are options to, through bronchoscopy, you can treat the bleeding vessel. So, but investigation again depends on whether the patient is going to live for a longer time, or patient is in a terminal stage. So that should be the deciding factor. So if you already know that the patient has come to you many times with the history of hemoptysis, and this is this time that you are seeing the patient with the massive hemoptysis, then you would have already explained to the patient in one of your consultation that in case of massive hemoptysis, we won't be, do any invasive procedure. We won't say that we will not treat the patient, but we will be not doing an invasive procedure such as, endoscopy or bronchoscopy to treat, and also intensive care therapy. So it all depends on the kind of the stage of presentation, and how much rapport that you have built with the patient. And so the investigation will also depend on whether to what extent you can go. Sometimes massive hemoptysis can be a terminal event where you have to just let the patient go. Okay, so this is an ethical dilemma in for all palliative care physicians. Should we treat or not treat? I'm sure you would have had a session in ethics, which where they would have explained the principles of treating a patient in palliative care. So the pharmacological management for hemoptysis is anticoagulants to reduce or stop the bleeding. If there is a direct tumor infiltration is suspected, steroids can be given, trial of steroids. And if you suspect infection, antibiotics. That's why we needed those investigations. X-ray and MRI is asked to see whether there is a tumor invasion or there is infection. And in case of pulmonary embolism, you have to give antifibrinolytics to treat the embolism. And non-pharmacological is always, as we all know in palliative care, be with the patient, explain, and in case of massive hemoptysis, you use a dark colored towel so that the brightness of the color of the blood can be hidden, and comfort the patient, take comfort measures, keep the patient in a comfortable position. So these are the non-pharmacological measures that we can take. So any questions about hemoptysis before I go to the next?
As of now, there is nothing in the chat. If there is something coming up, I'll just read it.
All right. Okay, so the next bleeding presentation that we see is hematemesis. Hematemesis, where patient complains of vomiting blood, and they complain, may have discomfort in the abdomen. There may be mild distension, and they also complains of nausea. So you can see the vomitus can contain fresh blood or blood clots. So this color of the blood gives you the clue whether there was an old bleeding which is coming out, or patient is bleeding fresh now. Abdomen could be distended, and there may be tenderness in the epigastrium. And vitals also will give you the clue whether a patient is going in for shock or whether he's stable. And certainly from the face, you can see whether patient is anxious, and most of the patients are anxious. So management of hematemesis, again, we need to give anticoagulant to stop the bleeding. So tranexamic acid can be given, and some physicians also give injection vitamin K and IV fluids to keep the vitals stable, and blood transfusion, whether should we give or not give if patient is going in for shock. Again, as I said, it depends on the stage of the patient. If the patient is in terminal stage, or if you think that this is the terminal event, then we may not go for blood transfusion. So it depends on a lot of other factors that I've already told you, but this needs to be discussed with the patient caregiver and with your team before you start this treatment. So if the patient is, you also can consider, depending on these parameters, considering ligation of the blood vessel, bleeding blood vessel through endoscopy, and monitor vitals. And as I said, this could be a terminal event. I had a patient with hepatocellular carcinoma. He came with distended abdomen and with constipation. When we have admitted him, he had ascites. So the plan was to tap the ascitic fluid, because he was feeling very uncomfortable with the distended abdomen, and send him home. But after he was admitted, within 2 or 3 hours, he started vomiting blood. So it was mild to start with, and then he started vomiting more blood within some 30 minutes. So all these questions came up. Should we do blood transfusion, or should we start IV fluids? All those. He was already treated for his, he has undergone ligation of blood vessel. And we know that he was already in stage 4 for more than few months. So we discussed with the family, the caregiver, that treating him with blood transfusion and other things, keeping him in the ICU. This is a new patient we have never seen. So we need to take a lot of time to explain about the invasive procedures. So we didn't have much time. That day, that midnight itself, he had a massive bout of hematemesis. Within the span of 30 minutes, he passed away. So as I say that we need to really consider a lot of factors, whether we need to treat patient with IV fluids, blood transfusion, and other things. So this needs a careful consideration. But we do give anticoagulants and injection vitamin K, but that did not help him. So we also stopped monitoring vitals as we saw that he was progressing, was going on vomiting, because connecting even the monitors, that even the beep sound gives a kind of a feeling that there's something, seriously wrong with the patient. So we let the caregivers stay by the side of the patient and help with cleaning the blood and, so that they feel that they were part of the, treatment, and they could do something for for his loved one. And the end was peaceful. So we did use sedation to calm him down, but he was not very restless or anything. But just to reduce the anxiety, we gave a small dose of midazolam. So each case is different, and each case needs to be assessed individually depending on the parameters that I just listed out. And not everything is right and not everything is wrong. So you need to take decisions based on case to case. Okay, catastrophic bleeding. So the word itself is frightening. It means like it's life-threatening, So, but the symptoms are very subtle. You can't make out that the patient is going to, die or have a bleed like this. So they usually say there's a feeling of unwell, that they're not feeling well. There's something, something is wrong with them, but they may not be able to tell, especially if it is an internal bleed, like hematemesis, or they bleed, or IVC rupture. Those things, they won't be able to exactly tell. They may not even have pain or anything. Of course, bleeding from a malignant wound, yes, of course, you can see visibly something, and patient also can tell you, that they are feeling something there. So it's a feeling of impending doom. This is very vague to, find out. But the clue is that maybe small bleeds in the past. It could be like, as I already said, that the small bleeds from a malignant wound or a eroded blood vessel, or it could be mild hematemesis or bleeding per rectum or vagina. So that kind of give us the clue that this patient may go in for catastrophic bleeding. So when we explain end of life care, especially when patients are going to be treated at home, at the end stage, we may tell the possibilities of what may happen towards the end. So this bleeding could be one of the event where patient can, end the life. So vitals also give you the clue whether the patient is going to, whether the patient is going in for bleeding or going in for internal bleed, low pulse and low blood pressure. So that gives you a clue, especially in case of internal bleeding. Bleeding which you can see from the malignant wound, definitely there is always something that you have time to be prepared. So I had a patient with CAPNS and the left inguinal region that eroded the inguinal artery and also the major artery there. So he was admitted with mild bleeding, and with a pressure bandage and things like that, the bleeding was under control. But he was already in stage 4, and he was a very young patient. And so we sat with the family and explained that he could bleed, heavily anytime. And so that may be, the end. So the patient understood, the family also understood that that's going in for treatment or putting in ICU or blood transfusion or not going to help. So on the day the third day, he suddenly had a massive bout of bleeding, and in the ward where he was admitted was like, it was really like a fountain. and it was blood everywhere. It was bleeding from the artery. It was over the walls and ceiling. It was with so much pressure that we hardly had any time to do, to control it. And it just died in few minutes. And the nurses could do only come and put the bandage, whatever she could grab in and keep it there, but it was uncontrollable bleeding. So that's why I always put, the first thing is to explain anything that is catastrophic that you may suspect. The first thing is to take time to explain the patient. If even if the patient present with bleeding, one of your colleague should take time to explain the patient that it is, or the caregivers, that it may be catastrophic, it may be terminal. So we may not be doing everything, but everything to comfort the patient. So explain and position the patient in a comfortable. Yes, there's a question, I think, from Meera.
Yes, ma'am. I have one question.
Yes.
Yes, I'm Dr. Gan speaking. In a scenario where we have massive bleeding, is there any role for a surgical procedure which is likely to stop the bleeding, but the patient is in a very terminal stage, where we don't have any, where the possibility of him surviving for a reasonably long period is minimal?
Sorry, I didn't understand your question. If the patient is terminal or not?
If we are, can we go in for a major surgery? Major surgery has got its own risks and all other things, including financial, where we think that the major surgery might be able to stop the bleeding. But the patient is a terminally ill patient where the survival is very short. We know that the patient is unlikely to be alive for a long period.
Yes, we can go in for surgical procedures such as ligation and whatever that is possible. But in case of catastrophic bleeding, I don't think there will be time to do any surgical procedure. So, like the case scenario that I have described, you may not have time except to contain the bleeding with the pressure bandage. But in case where the bleeding stops, luckily if the bleed stops, and you think the patient will not die immediately, may survive for a week or so, there is no harm in doing ligation and procedures like that. So again, as I already said, that it depends on the stage and the kind of presentation. So all this and the ethical principles, it's based on all of the factors, whether you want to do any procedure on the patient or not. Yeah. Okay, so are there any more questions? Okay, so then we'll continue with the presentation. So explain, position the patient and sedate the patient, as most of them are angios. So usually diazepam group of drugs such as midazolam, we can go up to 10 milligram to keep the patient calm. So when we say sedation, especially when the patient is terminally ill, this dose is to calm the patient down. It is not to hasten death or anything. So that we need to make clear with the caregivers. So most of the time people think that they misunderstand that we are going to sedate so that he can pass away quietly. So you have to explain the side effect. The main effect is to calm the patient down. The side effect is sedation. So the intention of the drug administration is different. So that we need to be very clear. So non-pharmacological measures, use a dog-colored towel or clothes if the patient is bleeding. from the wound. And also if they have hemoptysis or hematemesis, to wipe the towel to keep, so better to use a dark colored towel. And would you reassure that it's going to be all right? So I don't think so. We cannot reassure the patient that everything is going to be all right. So this, we can only say that we are taking every measure to comfort, to keep things, smooth and calm. So some people, they'll say everything is going to be fine, you're going to be all right. I think we shouldn't be using such words to give false reassurance, but rather we can say that that we are taking every measure to keep you comfortable. So the patient understand that he's only comforted. And be with the patient and family. It's very important that your presence makes a lot of difference. As you have treated the patient at the last few months of life, and don't disappear from the scene when the patient really needs you. Some of us feel very distressed to be there, to see our patient passing away in such a, in a very distressed way, like having a massive bleed. But I think we need to have the courage to, can't be there, then ask one of your colleague to be there to until the end. So, I mean, that's what they remember. So not your, treatment or whatever, but they remember that you were there until the end and you did not leave them alone. So that is a very important non-pharmacological measure that we need to remember.
But I think we have a question from Dr. Usha. She wants to know what are the positions of ease in patients with catastrophic bleeding?
What are the positions of
ease? EASE, ease. Like
to ease? Okay, to ease. Again, it depends on from where the patient bleeds. So if it's emergencies, keep the head raised. So that patient can, when they vomit, he may not choke, and he will also be comfortable because the abdomen is very, they may feel discomfort in the abdomen. So this position may be comfortable, but some people may not like to be the heads raised. So ask them to turn to the side. So it depends on, it's a deal between you and the patient. So our intention is to not to harm the patient, and also to keep the patient comfortable. So it should be comfortable for the patient as well. So we remember, if patient is not allowing you to raise the head, then keep him on the side so that he doesn't choke when he vomits blood. So it's same with hemoptysis. And malignant wound bleeding, you will see where the site of the bleeding, depending on the site of the wound bleed, you have to position the patient. Anything else?
No, ma'am.
Okay. Okay, any other questions? General in this topic, hemorrhage? Okay, if there are no questions, we'll move on to the next topic. Stridor. So stridor is again like bleeding. It is again a distressing symptom. So patient present with a high-pitched breathing sound. Sometimes, you hear it's a noisy breathing, or sometimes it's like musical, but it is distressing. You can make out from the patient's face. So it could be due to intrinsic or extrinsic airway obstruction. Intrinsic obstruction is caused by tumor invasion, which could obstruct the airway, or it could cause inflammation. Extrinsic obstruction could be due to pressure from the external structures such as thyroid, or cancer thyroid, or swelling of the thyroid. So as you see, patient can have distressed breathing, and also you can hear the loud noise, so noisy breathing, and respiratory rate may be higher. There may or may not be cyanosis, and oxygen saturation at room temperature may be compromised. The management depends on, again, the stage of the disease, as I said, but the first measure is to relieve the obstruction, to keep the patient comfortable to breathe. So we need to use corticosteroids, dexamethasone, 8 to 12 milligram. And you can use supplemental oxygen, nasal oxygen, if if the oxygen saturation is low, and anxiolytic, midazolam, to reduce the anxiety. And should we do tracheostomy? Should we consider tracheostomy in this kind of patient? Because as patient present with stridor, it is something life-threatening. You can see that they are struggling to take breath. So again, it depends on the stage of the disease and the general well-being of the patient. So I remember treating a patient with CA tongue presented with neck swelling, and she basically came for oral thrush. She said she's not able to swallow, and she feels burning in the tongue. So and she also said she had neck swelling for the past few weeks. So on examination, definitely there was oral thrush, and she had big lymph nodes in the neck on both sides. And she had mild stridor at the time of admission. So we treated oral thrush, and swallowing improved. She also said she could breathe better. So we explained that she can continue treatment for oral thrush, and take opinion for the lymph nodes of the neck, whether it needs to be treated. So as we were planning to, discharge, that particular night she had a very bad stridor, means like her oxygen saturation went low. So we need to put her on corticosteroids. That is, we started with Dexa 8 milligram, and with nasal oxygen, and she was feeling better after some time. We also gave her a dose of midazolam. In the morning, patient's son came, and they already had discussed with the oncologist about this swelling, lymph node swelling, which is compressing on the obstructing the airway. So this is extrinsic obstruction. So they were saying, should we go in for a tracheostomy? Now this lady is, she's 94-year-old. She had no other comorbidities except this cancer tongue with recurrence of the neck. But her general condition is poor. She's very weak and she's not able to eat. She's not eaten for a long time, probably because of the oral thrush, and also she had associated loss of appetite. So patient's son who were in abroad, they wanted to go in for a tracheostomy. And we had to discuss with the sons who are here and then abroad. So the main driving factor to do a tracheostomy was the length of survival. Although in palliative care, we may not calculate the length of survival and things like that. But as is, the patient was not going to last for more than a few weeks. This is from the clinical judgment. And second, the neck swelling, lymph node secondaries, they were growing faster. And she was not a candidate for palliative chemotherapy. So that means eventually the swelling is going to compress the airway, and she may die because of choking. So even if we do a tracheostomy at this stage, considering that she might live for a few weeks, the surrounded lymph nodes, they may open up if they do a tracheostomy. So the position for tracheostomy also was not good as per the surgeon's opinion. So, and may take longer time to heal, or it may bleed from the lymph node swelling. So she was not a candidate for tracheostomy. So here we need to take a call that not to go in for tracheostomy, even though the survival is predicted is longer. But considering all this, we have suggested not to go for it. So it all depends. As I said, it is based on from case to case. What we have to make the patient comfortable, we have to continue to do that. And this patient lived for about 3 weeks after discharge. She did not have much breathing problem. We kept her on Dexol at 8 milligram OD dose, and oxygen SOS if she becomes distressed, and anxiolytic. And she passed away one night very quietly without much problem. She suddenly had a breathing problem, and then she passed away at home. So when we see the patient, we need to take a thorough assessment of all the factors, physical, psychological, social, and spiritual. And this lady had so much of spiritual problem, and that she didn't want to, continue to do anything to prolong her life. So it also depends on patient's wish, patient's autonomy. So this is about Strider. Any questions?
Nothing in chat, ma'am.
Okay. All right. Okay, so we'll move on to the next topic, terminal delirium. So delirium is one of the, again, one of the symptoms which can put the caregivers to embarrassment. And, it sometimes when patient comes to this, realize that he or she was delirious, it could, demoralize the patient, because the symptoms, when patients are delirious, their behavior is extremely different. So patient usually present with extreme restlessness, and they look confused, and they behave very abnormally. So they may cry out, and they may shout. They may not know who's taking care of them. So they forget, there is waxing and waning of memory. Suddenly they remember things, suddenly they may not remember who's their daughter or son. And they may see things which are not there, visual hallucination. There may be some fidgeting, like they go on do the same thing, like they fold the paper and keep it on the table, again take it and fold and keep it back. All kinds of funny things, So abnormal behavior, confusion, restlessness, these are all the symptoms of delirium. Terminal, white terminal, if the patient is, you're suspecting the patient is going to die in the next 48 hours, then it is called terminal delirium. So because towards the end, a lot of metabolic changes happens in the body that can cause delirium. So there are two kinds of presentation that I have seen in my clinical practice. One is hyperactive, another one is hypoactive. So hyperactive, we will not miss to diagnose. So because you will be seeing a very aggressive, patient is very aggressive. You can see the abnormal behavior, and they can look confused, and they does all kinds of things. and they also have visual hallucination. So it's very easy, when you see aggressive patient, you want to do everything to calm the patient down, and you know that it is delirium, and there is no problem in diagnosing or treating. The problem with hypoactive is patient is calm. It's all the time. They may doze off or they may be sleeping. And when they wake up, they look very confused. They won't be able to make out where they are and what is today's date. And, so they look very confused and their judgment is also impaired. They may open the door of the room thinking it's bathroom, and there is impaired cognition, and they also may have hallucination. In a drowsy patient, if you do not have high suspicion of delirium, then you tend to miss the diagnosis. So terminally ill patient, most of the patient may be drowsy. Could be because of the drugs that we are administering, opioids. It could be because of the weakness. As they are growing weak, they become drowsy. They may be in the bed for a longer time, or insomnia can cause drowsiness. So we may tend to miss the diagnosis of hypoactive delirium unless we look for other symptoms such as confusion, impaired cognition, and particularly as for visual hallucination. So pharmacological management is midazolam is a drug of choice. You can give up to 10 milligram in titrated doses, depending on the availability of route, IV, subcutaneous, sublingual. Usually that helps. And levomiprazole also helps, just like you can go up to 25 milligram in titrated doses, along with midazolam. And if patient is already on diazepam or haloperidol, you need to stop it because these drugs are known to cause delirium. And also look for treatable causes of delirium, such as fecal impaction, urinary retention, drug overdose, particularly opioid in an elderly patient. And dry mouth can cause delirium. So don't take dry mouth lightly. And any underlying infection. If there are no acute symptoms of infection, such as fever, patient can just present with restlessness or drowsy. The caregiver might say that, my father has been sleeping for a longer time now. So infection could be one of the reasons for delirium, and hyponatremia. Particularly in elderly patient, hyponatremia could be the cause for delirium. Okay, so apart from giving these drugs, you also look for the reversible causes of delirium. So non-pharmacologically, we need to keep the patient in a familiar environment. So I treated a patient with CA endometrium with, I don't think she had brain metastasis. Yeah, she had CA endometrium recurrence, and she was not on any treatment. She had, when she came to us, she had just lower back pain, and she was started on tramadol, and then she was kept at a full dose of tramadol with SOS. She was doing well, and suddenly one day she developed abnormal behavior. So the caregivers said that she is behaving very strange. She doesn't recognize who's the daughter and where she is. So she was shouting. She was going on talking to herself. She was talking to the wall. These are the things happened, and they want to keep her at home. Towards the end. So when these things happened, so I asked, ruled out all the kinds of things, urinary retention, fecal impaction, all of that. And the only clue that I could get from the caregiver is she was living in her house, but she now had gone to her daughter's house. From the time that she went, she started behaving abnormally. So started a small dose of midazolam, and then I told them if possible to get her back to her house. So they said they couldn't do it immediately, but on the third day they shifted to her house. And you will not believe she was completely all right. She was able to recognize people and she was normal. Absolutely, she came back to normal. So environment plays a role in treating delirium. And remember, somehow in my experience, darkness triggers delirium. It aggravates delirium. So keep the lights on and let the window open and keep a clock and calendar in the room so that they are oriented, they know where they are, and that could reduce symptoms of delirium. Okay. Questions? Yes.
Stopping midazolam and stopping diazepam and starting midazolam. Why should?
Okay, so diazepam is known to cause, it can cause delirium. That's one of the side effects. But midazolam is a newer group of diazepam, which is which will not associated with delirium. Did I answer that question?
Dr. Meera? Oh, yes, she has answered yes.
Thank you. So we'll move on to the next topic, spinal cord compression. Spinal cord compression is an emergency. It's a both oncological and palliative care emergency. So patient usually present with back pain. It could be a new back pain that patient is developing, which could get worsened very quickly, and it grows more severe. Or in patients who already had back pain, this pain become severe. So this is indicative of spinal cord compression. And also the pain becomes, pain relieves when the patient, pain becomes more when the patient lie down. So that's another clue that we are suspecting of spinal cord compression. Whereas in mechanical disc prolapse, when the patient lie down, usually the pain gets relieved. That's what they say. In addition to pain, patients have loss of sensation or altered sensation. So there could be numbness at the dermatomal level, or patient can have altered sensations such as burning or tingling or shock-like pain that can radiate down the limbs. There may be weakness of the limbs, and patient may not be able to walk or take a step further, or may not be able to move the fingers or arms like before. And loss of sphincter control, that is loss bowel and bladder control, could be one of the symptoms that occur very late. So if we wait for these symptoms to occur to diagnose spinal cord compression, then we are too late. Patient could have already had developing, going in for paralysis. So if you see the first three symptoms, then you should suspect of spinal cord compression, especially in malignancies where it tends to metastasize to the spine, such as lung, breast, thyroid, and renal. So an examination, we can make out there is a spinal tenderness, and there is loss of sensation at the dermatomal level. You can make out where exactly the the compression could be. So there could be loss of sensation, for example, at the T7. Or sometimes it may be, you may not be able to make out this. There could be motor weakness, like the power is compromised, there is exaggerated reflexes, and loss of grip, or patient may not be able to take the step in case of lower limbs. So there may be full bladder. If you look for that indicates loss of sphincter control. So management, the first thing that we need to do is to minimize the mobilization. Keep the patient in one position as far as possible. If it is cervical bone, then you need to get the collar. And if it is thorax and lower pelvic, lumbar spine, then you need to keep the patient lie down all the time. So that's very important. That will reduce the paralytic. That will prevent from patient going in for paralysis. And the immediate thing that we need to do is arrange for an urgent MRI scan to see where the cord compression is, and so that we can plan the treatment. So I think this this MRI here, you can see this cord is compressed at the T7 level. You can see this is the spinal cord, and here it is kinked, and you can also see the disc is compromised on the side of the T7. So that while you wait for the MRI, we can start the patient with corticosteroids, dexamethasone 8 to 20. We can go up to 24 milligram depending on the severity. If the paralysis is already set in, then give the highest dose, and then titrate it depending on the response. And definitely in consultation with the radiation oncologist, as the patient needs to be undergo radiation therapy for the spine. And of course, there's always a dilemma, whether palliative care physician should take care of cord compression or the radiation oncologist. So it is, I would say it is both of us should treating the patient together. While they're treating the patient with radiation and things like that, we can always help palliate the symptoms. You can treat back pain because patient pain is already gone high. And if paralysis has already occurred, then we need to teach the caregivers to take care of the skin, doing the immobilize the limbs, and how far they can take care of the passive exercise of the limbs. So bowel and bladder care. So all those things needs to be taken care by palliative care physician. Any questions? Cord compression can be reversed if we identify at the early stage. So this is one of the treatable conditions in palliative care emergencies. So as soon as you suspect, then you start the patient with the dexamethasone before they they do the MRI scan and get started with the radiation. So no time should be wasted in starting the treatment for this cord compression patient, because if you delay, the patient is going to end up in paralysis. So there are no questions. We go to the next topic. I think that's the end of the slide, I guess, for SVC obstruction. Yes. So SVC obstruction is again another distressing emergency that we see in palliative care. So patient present with swelling of face and neck, and also complaints of difficulty in swallowing and breathing. Patient may have stridor and a cough. So this is very common in patients who have mediastinal tumor. So mediastinal tumor compressing on the SVC could cause obstruction. So if you see a patient already diagnosed with mediastinal tumor, presenting with swelling of face and neck and difficulty in swallowing and breathing, immediately we should suspect of SVC obstruction. So on examination, you will see a swollen face, neck, and sometimes arms. There's a dusky skin of face. I don't know, this description is very Western description. We don't see it in Indian patients because of her skin color. And there could be distended veins over the face, neck, and thorax. And you can, maybe in certain cases, you may be able to elicit Pemberton sign, where you ask the patient to raise both arms and you see patient can go in for cyanosis. The whole, the face, lips becomes blue. So I have seen in one patient with Pemberton sign. And obviously patient is dyspneic. You can see that he is not able to breathe. This is again an emergency, needs to be treated immediately with corticosteroid to relieve the obstruction. So dexamethasone 8 to 16 milligrams. And wherever you treat dexamethasone, I'm sure you have learned in your symptom management module that it needs to be combined with gastric protective drugs such as proton pump inhibitors. So because Dexa is, unless it is given for a trial period for 3 days, if you're planning to continue the patient on corticosteroid for a longer time, then better to combine with a PPI. And give supplemental oxygen as patient becomes blue or oxygen saturation is reduced. And immediately radiation of the mediastinal tumor that will help relieve the obstruction. And stenting of SVC, again, depending on the stage of the disease and the presentation of the symptom, and in consultation with the interventional radiologist, we can think of stenting SVC. That's all I think. So these are the references you want to refer to. So, any questions?
Thank you, Dr. Bharti. We'll wait for a few minutes if someone has any questions. You can either unmute from your side, participants, or please type it in the chat. Because these are the emergencies, most of them we commonly encounter in our settings. So if you have any questions regarding the management or how to approach, please feel free to ask.
You can add if you have any points to add, Dr. Sridevi.
No, you have covered all the points really well with your experience with patients, and that's, I mean, this is precisely what we also practice. There is nothing much different.
Okay. There could be other conditions which are not very specific to palliative care. It could, such as DVT. DVT could be, it's a common presentation in any other illness. So, so those kinds of things I have not covered. DVT, seizures, and I think as physicians we have already learned how to treat them. But these topics are real emergencies, particularly in a palliative care setting.
There is a question on tumor lysis, but there is no specific question, just tumor lysis.
Okay.
Dr. Bharti, would you like to stop sharing the screen so that you will be able to see the chats also?
Okay, I'll minimize, stop it. Okay, right.
Yeah. And Dr. Meera has raised her hands. Madam, please go ahead with your question.
Hello. Can I ask a general question?
Yes, please, please.
Yeah, this can be answered by anybody, so it's not directed towards anybody. I was wondering, given the different scope and the broad definition of palliative care, when we talk about this treatment or the palliative care in the emergencies, for example, when we give it in the terminally ill patients, we call it as palliative care. And when we give it to other patients who are not going to die, for example, in adult probably we might call it emergency interventions. The difference could be only that in the palliative care, of course, because of the organ failures and all, there might be certain contraindications of certain treatment and drugs. So I was wondering the scope and definition of palliative care in this context.
Dr. Sridevi, do you want to answer this question?
Maybe, so what you have mentioned is true. But along with that, maybe I think Dr. Bharti was mentioning in between her presentation also. Here, your goals of care is a little different because patients usually facing these emergencies will be in an irreversible trajectory of their illness. Very well, even if you take the example of bleeding, if you see bleeding in a patient who's on the correct curative management, probably you can do many treatment measures to stop bleeding so that they can continue with the treatment. But when you see the bleeding emergencies in patients in palliative care, usually it will be very terminal, like you asked about the intervention. Usually we give time just to take the dark towels and give the injection, not more than that. A few minutes probably in your hand. So I think goal of care would be more on keeping the patient comfortable than probably reversing what has caused the emergency. I think in the general medical emergency or in patients with curative intent, probably your goal of care would be to reverse. I mean, that's what I can think of. Dr. Bharti, anything?
So I
Yeah,
think
that is true. That is actually true. I don't deny that one, but I was just wondering because the treatment remains the same more or less in terms of the emergency. Whatever you have to do for the bleeding, you have to do it for the other patient also and the other one also together. But the goal, no doubt, is different, and by definition also is different. Thereby, what I want to suggest is that do we need to add something in the definition of palliative care, apart from that it is for to improve the quality of life and terminally? Just a thought. I might
Yes,
be
sir.
wrong.
I think, yeah, that's a very good thought. I think many places people name it supportive care than palliative care or palliative medicine and supportive care. So that, I mean, yeah, it depends. Yeah, you're rightly said. Sometimes we need to talk about I think there was a very big discussion during one conference regarding the name that should be given to the specialty, whether it is palliative care or supportive care, what people generally prefer to call it. Thank you for sharing your thoughts.
there's a question in the
There is
chat.
one more question, I think. Any difference between, I think that's for you, Dr. Bharti, or general palliative care and geriatric palliative care?
Okay, so in my understanding, there is general palliative care and the specialist palliative care. So general palliative care is where people with from any kind of discipline can practice palliative care. For example, it could be oncologist who can practice palliative care, or a neurologist can practice palliative care. But specialist palliative care is where people who are specialized in palliative care and those who are like, gone in for higher degrees and had so much experience treating only palliative care. So it's called specialist palliative care. So just want to make the things clear first. So geriatric palliative care is where it's a kind of specialist palliative care where the palliative care physician can acquire the knowledge in geriatrics and combine both skills, palliative care skills that you've learned, and which is particularly applicable in a geriatric population. So that is geriatric palliative care. A geriatrician practicing palliative care is, according to me, is still a general palliative care. That will fall into a general palliative care category. But if a palliative care physician specialized in geriatric, then it becomes a specialist. So what is the difference is that there are certain conditions which are specific to this kind of population. For example, frailty and fall. These are all and malnutrition, dementia, for example. These are very, very specific to geriatric population. So geriatric palliative care, where the physician keeps treating these patients day in, day out, and they become expertise in treating this patient, unlike general palliative care physician. So they become kind of experts. So it depends on the population that you choose and the experience that you gain in addition to your specialization. I hope that helps.
Thank you, Dr. Bharti. Any last questions before we wind up? I don't see any questions. If there is something unaddressed, please text us in the WhatsApp group, so we'll be able to get back to you with whatever suggestions from our side. Thank you so much, Dr. Bharti, for being with us for the last 1.5 hours with a very important topic on emergencies, and you have covered it really well. Like, you have covered whatever emergencies that we see, and I think we were able to follow it also because you try to integrate your patient experience also. That makes a lot of difference in understanding the management. Thank you so much for being with us in this training program. And thank you all the participants for being interactive and asking questions in the chat or unmuting yourself and sharing your comments on that. Thank you so much, Shripriya.
Thank you, Dr. Sridevi.
It was really nice having you in our session. Thank you for accepting our invitation and joining as faculty. And we do really look forward to have more and more sessions with you in future like this. Thank you everyone for joining and making the session interactive, as Dr. Sridevi said. And so with the promise that we'll meet again in the next session with yet another different topic and yet another eminent faculty. This is Sripriya along with the Dr. Barathi, Dr. Sridevi Warrior and Mr. Anup signing off from the Tips Report. Till we meet again, take care, bye-bye.